Hi everyone, my name is Paul Dirks. This is the second video that we're doing on what the literature really says about transgender related issues like gender dysphoria, like treatment. Today we're going to be considering what the studies say about long-term outcomes for transition and specifically treatments such as cross-sex hormones and in the main sex reassignment surgery. Just before we start, I'd like to point out that I love LGBT people. Whether it's my transgender friends, whether it's those who have detransitioned, who I'm coming to know more and more of their stories. But it's important that we understand that truth always leads to good outcomes, and what we're going to see in the literature is that really there are some exceptionally poor outcomes for the kinds of treatments that much of our culture and transgender advocates are saying is the solution to gender dysphoria. Last time we took a look at the studies on desistance and persistence. There's actually not that many studies on that, and so it's pretty easy just to kind of take a look at all of them. And we did up a spreadsheet that was able to point out some of the key statistics on persistence and desistance of gender dysphoria in children. What we saw is that generally speaking, in 80 to 90% of cases, gender dysphoria goes away after adolescence for these confused kids, these troubled kids. Even those that have the full GID diagnosis, in the ones that we saw, even there, there's tremendous amounts of desistance. Just to paraphrase Steensma in 2011, he says that it is the unequivocal finding of the literature that in the vast majority of cases, gender dysphoria remits after adolescence. So today we're going to take a look, kind of a first video on outcomes for treatment of transgender individuals, and or gender dysphoric individuals would be more accurate. And we're going to probably have more than one of these videos because the literature is larger and there's a number of different things that kind of work together and coalesce into trying to understand whether treatment such as cross-sex hormones and sex reassignment surgery really does help these individuals. So today we're going to focus on long-term outcomes, and let me give you a couple of generalizations before I take you to the literature. And take a look at some of these studies. The first generalization is that the long-term outcomes show vastly worse outcomes than the short-term studies. All right, and this is really important to understand that there are studies that show that people are helped through transition of their gender dysphoria, but in the main, these studies that show the good outcomes are generally they're shorter term studies, and things look quite a bit different when you get to the longer term studies. The second generalization is that the studies that are focused on the more objective aspects of whether the treatment helps are worse than the ones that have more subjective measurements. We're probably going to look at that more next time, but we'll see that probably even to some degree in what we see today. The other generalization that's really very important, and we're going to see this today, is that the studies that have the lower loss to follow-up rates show vastly worse outcomes, or at least significantly worse outcomes, than those that have the higher loss to follow-up rates. And so what we're kind of putting this all together, what we're going to see is that the better studies show the worst outcomes for those who have been treated for their gender dysphoria with cross-sex hormones, or especially sex reassignment surgery. So like last time, I have a spreadsheet that I'm going to bring up here, and let's see. Yeah, we're going to do this. Just give me a second. So this is our spreadsheet of all the studies of which I'm aware, between 5 or over 5 years of length as far as follow-up time. I've relied on some of the meta-analyses that have been done in the literature, like Murad's in 2010. Dejny did one a couple of years back, and but then also by reading the different studies. All of the ones on this list I've read. and then searching for ones that they've referenced and cited, and going and looking at those too. It's possible that this doesn't represent every single study that's been done, but this is the most this is the largest list I found anywhere. So it's possible though that there's a couple missing. This is I'm pretty sure though that the ones over 10 years, this is all of them. So what I'm going to do is I'm going to look over, we're going to overview the ones that are over 10 years here, and then I'm going to mention, after mentioning a few things as an overview, we're going to go back to a couple of key studies and look in some detail at them. So firstly here, let me just go over what we have as far as headings. We see that we've got the year, the author, where the study was done, the length of times in years of follow-up, whether the group were males, so this is obviously biological sex now, females, or whether it was a mixed group, the sample size. Red is, I think anything under, I think if I'm not mistaken, anything under 35 or 40, something like that, I've put in red. Anything over 100, I've put in green, just to give you a visualization. And then the kind of study, so if it was prospective, so if you can compare pre to post, whether there was improvements, for instance, then I've put that in as yes, and labeled that green. If there are controls that they've been able to compare to, that they've set up the study that way, then I've also put that in green. Loss to follow-up, we're going to see that is really important. This is the amount of people that they couldn't bring into the group. They couldn't study in comparison to the group they started with. And then the kind of treatment, whether it was cross-sex hormones, whether it was sex reassignment surgery, and then some of my notes. Most of my notes are based on psychological functioning. And the reason that is that psychological functioning is the reason why such drastic treatment is undertaken in the first place. I mentioned in our last study, you probably know this already, but gender dysphoria is treated in many cases by cross-sex hormones that are lifelong, and they're done off. The treatment is off-label. And there's tremendous and then you've got sex reassignment surgery, which is double mastectomies, genital reconstruction, sterilization from cross-sex hormones. So you've got some really serious treatments, and the reason they do such serious treatments is there's this idea that psychological functioning, if you don't get those treatments, is so poor that they're necessary. So this is then what we're going to be looking at, not just whether for instance, whether the sex reassignment surgery looked good, or those kinds of things, not just physical measures, but actual, whether it helped suicidality, for instance, is one of the key things we're going to look at. So 2016, Van der Sloos, Netherlands, this is to be the first one we're going to look at, and we're going to go over this very quickly because most of the measurements here were completely related actually to physical measurements of a particular sex reassignment surgery, namely intestinal vaginoplasty. Tremendous loss to follow-up, although it had a longer time frame. Not really much here useful though when it comes to psychological functioning. The second one here on our list is Asherman, and this is listed actually here just in descending order from the longest studies. We're going to come back to this study because we're going to see it's one of the registry studies that has no loss to follow-up, and that is very key. You actually also have the largest group, the largest sample size that we find in the literature. The third study on our list is Kuhn in 2009, done in Germany. 15 years in length, decent amount of people, 55. Completely retrospective, although they did have controls, which was helpful. And interestingly, we see here under the outcomes that even though there wasn't a tremendous amount of focus on psychological function, that overall, this is a quote now, that the satisfaction was statistically significantly lower in transsexuals compared with controls. So this showed quite poor outcomes for sex reassigned individuals. The next one on our list is Simonson. 2016. We're going to come back to this one. Again, it's another registry study that has a very low loss to follow-up rate, a very good amount of individuals. We're going to come back to this. The next one is Ruppin and Pfafflin in 2015, done in Germany. Again, good amount of sample size was good. They did have a comparison between pre and post. And of all the studies, if I was arguing that long-term gender dysphoric individuals are helped by sex reassignment surgery, this is the study that I would key in on. All right, it showed very good outcomes psychologically, although there was no discussion of suicidality. However, what we see here, if we're going to come back to this idea, is that you've got tremendous loss to follow-up, where it's close to 50% of their group was lost to follow-up. The next study, this is a little bit of an older one, done in 1998, Rochefleisch, done in Switzerland. It was a mixed group, and again, here we have 75% loss to follow-up. Unlike Ruppin and Pfafflin, however, though, what they found was that there was a lot of, or very poor outcomes. So, quote, the social conditions and quality of life of the 13 male to female transsexuals had significantly deteriorated. So taking a look at the objective measures, 3 patients regretted the operation, 2 had a reverse operation, 2 of the 4 female to males suffered from depression and problems of addiction. Another objective measurement was that pre-treatment, pre-op, 1 was on disability pension, post-op, 9 out of the 13 were on disability pension, something that we actually see in quite a few of the studies where you have a lot of physical disability post, in a long-term follow-up. They say, we suspect that our negative findings are mostly because of the long follow-up time. So this is kind of in quite in distinction to Ruppin and Pfafflin. They do not find good follow-up or good outcomes, although this is an older study, so you have to take that into account. An older study yet, and the last one on the second to last one on our list of these long-term outcome studies is Lindemann in 1986. This was a small group, although here, it's interesting. I'll say something about some of these older studies that even though you've got older, the treatment is not as developed at this point with the older studies. There are some advantages to the older studies. Namely, you've got only 11 individuals, but you only have a 23% loss to follow-up rate, which compared to, for instance, Rochefleisch and Ruppin and Pfafflin is actually not bad. And one of the reasons is that in some of these older studies, you've got clinicians who, because they're dealing with a smaller group and because it's they're able to follow up, or maybe they make the effort to follow up and track down individuals. And you actually see this in some of the older studies where the loss to follow-up rates are not as large. Now with Lindemann, you found that there was the outcomes were not terribly good. Excuse me, I do have a cough. Among the losses to follow-up was a suicide. You had a 30% regret rate. He says, our own findings are in accord with the rather pessimistic reports cited above. In conclusion, therefore, it seems reasonable to expect only marginal improvement psychosocially after surgery. So another study that would be somewhat negative about the outcomes. The last one we have here, and probably the one that is the best known, is Desjardins in 2011. It was over 10 years, and it depended on what they were looking at as far as the measurement of how much time, but both measures were over 10 years. It was a mixed group. Second largest follow-up group that we've ever seen with 324. They did not. There was no pre to post treatment comparison, but Desjardins did use controls. And so again, you've got no loss to follow-up, and the reason is that Desjardins 2011, together with Simonson 2016 and Asherman 2011, are the 3 studies that have that are registry studies where, to get around the issue of tremendous losses to follow-up, they're taking a look at only strictly objective measures that are found in the registries of for instance Sweden or Denmark. and looking at things like, the amounts of deaths, taking a look at the amount of psychological diagnoses, very objective measures, and they're able to get over this tremendous limitation that so many of the studies have, which is the tremendous loss to follow-up. So we're going to dig down into these studies a little bit more. All right, let me just yeah, so let's go back to these here. Give me a second. All right, so here we go. This is Asherman that we're looking at here on the right. And what Asherman found in his group that was, again, it was very large, over 1,300 individuals, is that there were 67 deaths and 18 suicides. And many of the causes were unascertainable. So the 18 suicides are just those that we know. This is what Asherman says. He says the external causes of death were increased almost 8-fold due to suicide and illicit drug use. The suicide rate in male to females was increased 6-fold. 13 out of the 17 had received psychiatric treatment in the past. Okay, so some more detail there about those who had committed suicide. No suicides occurred within the first 2 years of hormone treatment, while there were 6 suicides after 2 to 5 years, 7 after 5 to 10 years, and 4 after more than 10 years of cross-sex hormone treatment at a mean age of 41 years. The female to males did not have elevated mortality. This is pretty consistent, actually, with the literature that, generally speaking, there are a few outliers, but that the female to males tend to do better psychologically than the male to females. It's a big generalization, but generally that holds true. But the male to female group was, a much larger group in Asherman, and is usually the larger group in most of these studies, except for the newest ones, because the ratio of those who are being treated for gender dysphoria is skewing currently, which is something we'll take a look at in a subsequent video. So you've got significantly elevated mortality here in Asherman. Let me see if I can pull up that study. Here it is, done in 2011. So again, in just taking it right out of the abstract, in the male to female group, hopefully you can see that, total mortality was 51% higher than in the general population, mainly from increased mortality rates due to suicide, acquired immunodeficiency syndrome, cardiovascular disease, drug abuse, and unknown cause. So this was one of the first studies that really demonstrated that long-term outcomes may not be good for this group, in which we can take a look at the entire group where we've tried to address this issue of tremendous loss to follow-up rates. Next, let's take a look at Simonson, 2016. So this is the most recent of the studies that are the registry-based studies. This one was done in Denmark. So because they haven't been doing sex reassignment surgeries quite as long, it's not quite as large of a group, although it is over 100 individuals. And the interesting thing here about Simonson is that he was able to compare pre to post. So even though it's not a prospective study, he was able to take a look at the psychiatric diagnoses that were done, that were assigned prior to treatment, and compare that with the psychiatric diagnoses after treatment. So you'll actually notice on the spreadsheet that I have not said yes to pre to post because it's not prospective. They're just taking a look at a couple of different measurements, but the ones that we have are helpful. Okay, so here we have some of the details here about what they found, what Simonson found. So it says here, hopefully you can see this, pertaining to study aim number 1, we found that 28% of the study group had been diagnosed with psychiatric morbidity pre-sex reassignment surgery and 22% post-SRS. No significant differences were found between the number of male to females and female to male individuals suffering from psychiatric morbidity pre and post-SRS, although significantly more psychiatric diagnoses overall were present in the female to male group. Further, approximately 7% of the sample received a psychiatric diagnosis both pre and post SRS, indicative of psychiatric morbidity both before and after SRS. These results indicate that overall, individuals undergoing sex reassignment surgery in the Danish public health system hold considerable psychiatric morbidity besides gender identity disorder, both pre and post SRS. And then concerning what they found in regards to mortality, we read, in the present study, 2 deaths were due to suicide. Although this number is far too small to come to any conclusion, it is found in several other studies that individuals with transsexualism have a higher risk of suicidal ideation attempts or actual suicides. So here they found, even though the numbers are too small to really do any kind of evaluation on or analysis of, there was incredibly increased. It was a far larger amount of suicides and deaths than what they than would be expected, much higher than what we have in the general population, which I think he actually mentions in another place. So here again, you've got you do not have great outcomes long term in this registry study by Simonson in 2016, and this is the first study really that we have that compares a group, a group that's large enough, with no loss to follow-up, and where you're comparing psychiatric morbidity pre and post SRS, and it finds the same amount, statistically, in the 2 groups. It was a little bit of a lower amount in the second group, but it wasn't statistically significant, that difference. So again, it really calls into question whether this is this drastic kind of treatment is really helping individuals who have gender dysphoria. Let's look now, lastly, at in a little of a larger way here at Dejne 2011. Where do I have that one? Here we go. So this one is, I think this is the only one of the studies in the actual database there that I've mentioned that is open access on the web, and partly because it is why this study has received so much attention. Although partly too, it's because you've got some new information here that you don't have in any other study. So what Dejne found here, and I'm going to take you down to this table, and I'm hoping that you can see this. If not, you can follow along by pulling it up on the web yourself. But what you see is that you've got, so this is table 2, you've got death by suicide of 19 times that in control, that what she found in controls, okay? So highly elevated levels of suicidality, death by suicide. Psychiatric hospitalization is higher by 4 times. Suicide attempts are higher by 7.5 times. And then you've also got some other measures there about crime. So you've got some measures that are showing very poor outcomes compared to controls in this study. Also, what is helpful here is that you've got this longitudinal measure of when these deaths occurred and the deviation from controls and where those deviations occur. And this is important because we're going to take a look at a couple of other places quickly, although probably more in a subsequent video, where you do have some longitudinal studies. And what the longitudinal studies show, where you do have this information, is that sex reassignment surgery helps in some cases, maybe even the majority of cases, for a short period of time, 1, 2, 3 years. And after that, you start getting the usefulness, the help that it provides psychologically goes down. And this is exactly what you see in Dejne, where you've got a drop off after 10 years, a significant drop off compared to controls in cause of death. So this is interesting. Now, how do transgender advocates get around this data? What are some of the challenges that they'll throw at what we've seen so far? One of them, and I've started to address this a little bit already, and Desjardins herself actually says this, is that the older surgeries and not only the surgeries but the entire healthcare system, the stigma that was out there in society a long time ago, it's changed now, it's better now, and so the long-term outcomes that are poorer than the shorter-term outcomes are a result of things are better now. Whether it comes to society in general, surgeries in particular, and how they're performed. So that's something that transgender advocates will often bring up, and Desjardins herself brings up. Let me show you a couple of reasons why I don't think that's a good argument. All right, let me take you first of all I'm going to get there in a second. Let me take you to another longitudinal study. This is, I'll take you to the beginning of it here so you can see. This is Lindquist, and this is a 2017, so a very recent study. Quality of life. This title just blows my mind. Just showing that, at least in my estimation, that there is significant amounts of bias going on in with the actual authors of the study. So, quality of life improves early after gender reassignment surgery in transgender women. If I was, putting a title on this study, it would be something more like, treatment is only helpful in the first couple of years, for in gender reassignment surgery. So what we see here, taking you down to table 2, is we see, and there's not many studies where you have longitudinal data like this, where you have multiple waves, and I think this is the only one where you've got up to, where you've got actually 5 years. Now, the challenge here is that there is loss to follow-up in Lindquist, and so you lose statistical significance the further you go out. Nevertheless, you see actually quite a significant robustness of the findings. So let me just show you this, and hopefully you can see. Oops. Okay, I better stay there. So here at, prior to sex reassignment surgery, you've got these figures on mental health, vitality, bodily pain, social function, emotional role, physical functioning, and general health. This is the SF36 diagnostic tool. This is actually used in quite a few of the studies. So here, if you compare first, 1 year after, you've got significant, benefits to most of these measures. So, the emotional role goes from 69.5 up to, actually that one doesn't go up. Where are we here? But most of these do go up. You've got vitality goes up, mental health goes from 66 to 70. But then after the 3rd year, you start to see some drops. And then by the 5th year, if you compare the 5th year to the 1st year, you're finding measures that are either the same or, in fact, worse. So, for instance, bodily pain is worse. Social functioning is worse. Emotional role is worse. And so, now what is true that in this study that the author states is that because of the loss of statistical power in the later years, because you do have loss to follow-up, there's no statistical significance to this drop in numbers. However, you can see that there's really robust right across all the measures. And not only that, but this is consistent with what we see in the longitudinal data, that the longer you go out, the worse the outcomes are. So I would take significant issue with Cecilia Desjardins' interpretation of her study. I don't think it matches what we see in the rest of the literature. And in fact, I've had some email conversation with Desjardins, who's been kind enough to answer questions when she likes the questions. She doesn't answer the questions when she doesn't like the questions. So that's interesting. It makes me wonder what she's hiding. But anyway, so this is interesting. Let me tell you too, though, that other authors, when they cite Desjardins' work, often don't take Desjardins' perspective. So this is Marshall, 2015, who does an overview of the literature on suicidality related to transgender individuals, and says concerning suicide rates in trans people post-treatment that these findings were confirmed in an impressive follow-up study of post-treatment trans people, Desjardins. The authors found that the overall mortality rate for sex reassignees was higher than for controls of the same birth sex, particularly death from suicide. They also reported that sex reassignees had an increased risk for suicide attempts, suggesting that the suicide risk for the trans population may not be reduced after treatment and transition. And you've got lots of others that cite Desjardins in similar ways. And so, Desjardins says, oh, we can't, because we don't have a comparison between pre and post, you can't derive any kind of information about whether this was a successful treatment. Well, yeah, okay, on one hand, but on the other hand, you've got, after post-treatment, you've got 19 times higher levels of death by suicide. And you've got people like Marshall that are saying, listen, this is what Cecilia Desjardins has found, that, there may not be reduced suicide risk after treatment and transition. Let me just mention one last study. This is Adams 2017, and I'm going to make this a little bit larger. And what Adams found in a meta-analysis of the literature on suicide is that the lifetime levels of ideation and an attempt were 55% and 29% in kind of the meta-analysis. Past year ideation was not much less. 50% suicidal ideation over the last year for trans individuals, and 10% of attempt over the last year. All right. Now, interestingly, though, looking at before transition, you've got less ideation. All right, suicidal ideation, than even in the past year of treated transgender people. And then you've got just slightly elevated attempts than past year. But you compare, you start making these comparisons, and you're just in wonder that sex reassignment surgery and cross-sex hormones are used as treatment when clearly the suicidality is not going down where we have access to that information. So this is the case here where you've got somebody who's, and I know because I've read through the study and the way Adams presents the information. Adams is a transgender advocate, a sex reassignment surgery advocate. And this is what he says: it seems counterintuitive, on the other hand, that suicide attempts are lower before transition than over most other periods. So that is quite something. So let me just finish up by going back to our generalizations right off the top. Firstly, that I would say that the outcomes are poor, for transition long term. But at the very least, an entirely defensible generalization is to say that the long-term outcomes are vastly worse than the short-term outcomes. All right, and that should be troubling. The second generalization was, and we didn't really get into this as much, we probably will in a subsequent video, is that the objective measures show worse outcomes than the more subjective measures. We're going to unfold this a little bit more in another video. And then the third generalization was that that the studies that have the lower loss to follow-up rates, including quite a few that have 0 or very close to 0, show significantly worse outcomes than most of the studies that show that have higher loss to follow-up rates. So what I would say is that this just shows that we really need to make sure that we are looking at what the literature actually says about sex reassignment surgery, about cross-sex hormones as treatments, and make sure that we're not throwing rose-colored glasses on when we see that these kinds of treatments are not helping gender dysphoric individuals. We need to find other ways of helping these people. Thanks. Hopefully there'll be another video coming out soon. We'll look in a little more depth at some of these things.